coordinator at the local level and is helping lead Iowa's diabetes prevention efforts with key partners across the state. She will be with Carol Hibbs, who is the CEO of Marshalltown YMCA-YWCA, and since 2005, Hibbs has been the chair of, Carol's been the chair of the Marshall County Healthier Communities Coalition. In this role, she has secured funding for a number of programs, including the YMCA Diabetes Prevention Program, and she has previously served as chair of the Iowa Alliance of YMCAs on the Y of the USA Healthier Communities Initiative National Evaluation Panel, and on a variety of boards for health and culture organizations. Carol has a Bachelor of Science from Iowa State University.
Good afternoon. Thank you for sticking it out with us. I looked at the time, I'm like, I always get the 2 o'clock spot, and everyone, if you're like me, I'm ready to take a nap at 2, so appreciate it. This is just a disclosure. So really what we're going to be looking at here is some different models that the Cerro County Department of Public Health has gone through over the past 3 years building their program, and we've really gone into 3 different phases. So back in the fall of 2015, we were doing research and looking at the CDC program and really the NDP curriculum and trying to figure out whether or not this was a program that we felt was worthwhile in investing resources and staff into. And so we did start some sessions, and we offered them for Wednesdays and Thursday evenings through September to December. This was a pilot project, and so it really didn't completely follow the NDPP curriculum and the timeline. We were really just fact-finding at this point. The overall goal was we wanted to assess whether the public felt this was a needed service. If we threw this out there, were they going to come? We also wanted to get feedback from those participants once they got into the program. Our big concern with it was that it was a year-long program, and were people going to stick it out that long? We later found out that was an untrue myth that we learned very quickly, but that was something that at that point we wanted to find out. And then we wanted to see, does the program work? Do we really want to offer this program? That was really what we were after. So we had 31 participants that actually signed up. Our program is free. I'm sure that had something to do with it. We had very positive feedback from the individuals. In fact, they wanted it longer, and they were sad to see that it was going to close. We had 17 people that actually completed the program, and as I go into this presentation a little bit further, I'll kind of talk to you about this has been a struggle and what we've done to address that issue. We ended up dedicating another 6 months after the first 4 months to be able to keep that program going for those individuals so they can sustain the outcomes that they were getting. Just in the 4-month period of time when we first offered this, we had 105 pounds of weight loss, 115% increase in physical activity, and then our obesity, overweight, and healthy weight rates actually improved greatly. I was very shocked in this short of amount of time how those weights changed, at least through the BMI index. So the next thing was, yes, we want to do this program. It was great. And so we applied for the CDC's DPRP in November, and that should have actually been 2015. That's a typo. Once we realized by then that this was something we wanted to do, we wanted to go ahead and get started with that program. We actually sent life coaches. There was 3 of us that are trained. That was before we had some, I would say, statewide life coach training, so we were flying all the way to Chicago to get the training. I'm going to put a quick plug in, she's gone now, but there is a lifestyle coach training coming up in January. They don't happen very often. You can go on the Iowa Department of Public Health's website in the DPP area, and it'll give you the dates and the registration. I think they've offered like 2 locally in the state. They're hard to come by, and they don't have a lot of need, but as we're starting to see these programs go, take advantage of it if you want some lifestyle coaches to be trained, because it's far and few between. We continued to keep classes free for the participants, but part of it was because we received a grant through the Iowa Department of Public Health through a Community Health Needs Unmet grant, and so that allowed us and helped support that for a while. We continued to hold 2 classes, and we'd always do a morning and an evening class. We typically After the first pilot, we did pick a day of the week. So if we did a 10 a.m., it was either both on Wednesdays or the next group was on Thursdays. There's 4 cohorts through this model that we did, 8 classes total, and it worked great. I wish we could have offered a little bit more often. So we had some recruitment strategies. Again, we had that grant, so we had a little bit more leeway in trying to get some marketing out. But I can tell you one of the best things that we were able to do was I worked with my IT department and we took the CDC's pre-diabetes quiz, and he was able to convert it on our website, and it would provide a participant their score and their feedback after they completed the quiz. If they scored high, we gave them a link to then enroll into our program. So 2 things happened at that point. One, people were able to take this quiz and kind of get a general idea of are they at risk for pre-diabetes? Just knowing the awareness of where am I at with that. We had 390 people in this particular marketing strategy that took the quiz. And what brought them there was we bought a $99 Fitbit to give away. So that's pretty cheap marketing. We did it through Facebook. We let people know, take the quiz, you put your name on a list, and you can win a free Fitbit. And we also got about, I want to say at least 30 participants for our classes through that. So once they tested high on the risk assessment, they enrolled in our program. So it was very, very successful. I also did presentations with our medical sector. I would talk to health coaches. I'd go in and do, they'd have a monthly meeting, and I went in and talked to them. We had some nurse meetings and some office manager meetings. I was pretty strategic in making sure I didn't overpromise at this point, because we did only have 2 lifestyle coaches and 2 classes going every 6 months. So I didn't want to bombard my lifestyle coaches and then upset the doctors because they were referring clients that we couldn't provide services for. We did some bus wraps, some media interviews, social media. I will tell you that social media is our #1 way that we get referrals into our program even today. Our second #1 is our participants that have taken the program, and they're going out and they're talking to their friends and family. They're also talking to their medical providers when they come in. The providers are saying, wow, what are you doing? You've lost 20 pounds since the last time I seen you. That's also been more effective in getting providers to refer to our program than me going to their meetings and saying, hey, this is a great program. So that's been kind of neat to see. Through this model, we've had 129 enroll, 69 completed it. You're going to see that we have a 53.4% retention rate at this point. What we learned is, again, the program's free, but free isn't always good. What was happening is we were having people enroll into our program that maybe weren't quite ready to make that commitment, and there was no skin in it for them. They enroll and then they would drop out. Meanwhile, we had other people on our waiting list that wanted to get started and had to wait 6 months, so we lost that motivation in them. So we decided that there was something that needed to be done. We did have over 1,300 pounds of weight loss, and we were at 5.23%, which is meeting the CDC's DPR standards. So some of the challenges that we identified is we're still the only DPP program in the North Iowa area. I did go on the CDC's website this morning just to make sure there is one more program in our area, but I do not believe they're offering services at this point. So we have 4 lifestyle coaches, in Cerro County alone is about 43,000 people. So there's only so much that we can do, but we're going to work on that. The classes are filling up fast. So we were having a waiting list. Like I mentioned, we were only able to offer the program every 6 months with the current staffing that we had. And so there were times where we would just start a program, and then a couple weeks later somebody would get on our waiting list. And so how are we going to address that and keeping people still motivated? Because they want to make a change at that point, and it doesn't mean that it's on our timeline. We need to figure out how we can meet them on where they're at. We had a low participant retention rate. We were at 53.4%. And I also had some coach fatigue right now, or at that point, I had 2 lifestyle coaches, and they were pulling 2 classes at a time. They had their core session class and then the post-core. And it's a year-long process, so they were starting to get fatigued, and I recognized that. And then our grant finished up, and so now we were looking at what are we going to do to fund this. We're fortunate enough that we do have some county tax dollars through our public health agency that my health director dedicated for us. But again, as things change, those monies kind of get shifted throughout the department, and that was only going to last for so long as well. So here are some things that we did. We decided to do a quality improvement project to find out on the retention rate what was going on. So we sent out a survey. We surveyed current participants, past participants, and we included participants that actually dropped out of the program because we wanted to find out what was going on, what was keeping them there, what was having them drop out. So one of the questions that we asked was, were they hesitant to enroll, and if so, why? And what we, the number one was fear of failure. They were afraid before they even started. The second one was they didn't know anyone attending the class. And so when I talk to individuals, when I'm signing them up, sometimes I'll have that conversation with them if I can tell that they're a little hesitant. Do you have somebody in your household that's interested and willing? Do you have a friend? Do you have a sister? Whatever it is, we do see quite a bit increased results from individuals that actually do this together. We wanted to ask, why did they enroll? Of course, it's the weight loss, lifestyle improvement, and the program was free. Hence the retention rate that went down. Why did they miss classes? And we asked post-core and core, and it was the same. It was vacation, work conflict, illness. So we wanted to find out what motivators would have them attend classes more often. Recipe sharing is huge. As a lifestyle coach, I am actually the coordinator that kind of does the behind the scenes, but I will pop in and do classes once in a while if one of my facilitators is out. And if you're not careful, you can have this be a recipe sharing session all hour long. So trying to get them to regroup, but they do love those recipes. We have a private close Facebook page that we developed. They have to ask to join, and then my facilitators will let them in. And we encourage them, share recipes. If you find something that's that you like and you want to share it, go ahead and share the recipes there. Or sometimes they'll bring them to class and we'll hand them out. But we try really hard. We give them a little bit of time to go ahead and share those, but we try real hard not to let that overcome the entire session. This is a really small. The other thing that we wanted to find out is, because our program was free, was this an issue with our dropout rate? So we straight out asked them, if you had to pay $100 or less for this program, would that be a barrier in you joining? And we had less than 17% said yes, the others said no, if it was less $100 or less. We did determine that our high dropout rate was mostly in the post-core sessions, which is probably not unique to other programs out there. And we also looked at the attendance records and tried to determine, okay, is it mostly summer that people are not showing up? Is it winter because of the storms? And there really was no correlation in seasons or months either, so that wasn't an issue. So some strategies that we wanted to do to address low participant rate was to focus on the post-core, because that's where we were seeing our dropout rate. We, again, just like the speaker before, added additional classes. What we ended up doing, it was a little bit different, is during the post-core classes, we offered the same session, but we offered it on Tuesday and Thursday. So if they couldn't make Thursdays, or they couldn't make Tuesdays, they could make Thursdays. What we found out was they didn't make it anyways. That didn't improve. We tried to offer a little more hands-on, innovative type classes, especially in the post-core. We did address the objectives in the curriculum within those post-core, but then we tried to do like the grocery store tours. We bring in more guest speakers. We have a community walk where we'd all take a walk together. We have a really neat art sculpture in our town that it's actually a 2-mile walk, and so we all walked around and saw the art sculptures, and guess what, they walked 2 miles and didn't even realize it, so that's kind of fun too. And then at that time, my 2 facilitators would meet at least monthly to talk about what went well, what didn't work. They have a nice folder in their computer that if there's a really neat YouTube video that really went over well in that class, they put that in there, or if there's some activity that just worked very well, they can go into that folder the next time they hit that curriculum, and then they don't have to reinvent the wheel and they already know that it worked well. So this was all done through our quality improvement program, and unfortunately the results were inconclusive. We really didn't see much difference. And so we needed to go back to the drawing board. We really needed to expand our services, and then we looked about implementing a new payment system as well, or a deposit system. So while this QI process was going, we were also having discussions with our local hospital and YMCA, talking about expanding the program. Regardless of the retention, we knew that this program needed to expand to meet the services that were happening. We really wanted to look at increasing DPP offerings in the area. We wanted to be able to offer a local lifestyle coach training, because as I had mentioned at that point, you were having the closest that we had was Chicago, so we wanted to see if we could do that. We are very fortunate to have a very active community benefit ministry colleague that is actually in the audience, and I want to personally thank her because she's been very key to expanding our services. And she recognized this was something that was meeting their needs and what they identified with obesity and diabetes, and that public health was already doing this, and the Mason City YMCA was willing and interested in doing it, but they didn't want to reinvent the wheel either, so why don't we go ahead and partner and do this together as a team. And once we get the infrastructure in place, then we can go to those providers and say, hey, let's actively start screening and referring these clients here, because then we'll have enough lifestyle coaches to be able to provide those services. So in June 2017, we did bring local lifestyle coach training in. There was 4 lifestyle coach members that were going to be added to our team that went through that training, and then we opened it up across the state too, so others joined us. The one thing that I did learn through the process is if you're looking at selecting lifestyle coaches or expanding, and it was mentioned earlier too, be selective in who you want as a lifestyle coach. Make sure that it's the right fit. They may be very, very good at working with clients. What we found is a personal trainer had a hard time stepping back and being a facilitator. And so making sure that that fit is okay, that they can meet the role of what a lifestyle coach is really meant to be. Because unfortunately we lost 2 of those lifestyle coaches after we trained them. And so we still have 2 extra, but now we're looking at needing to expand again. We did offer classes with this new model last January, and we did again in July as well. And we're still following that evening and morning class so that we can offer those 2 different times to meet the need. We also implemented a refundable deposit, and so what that looked like is we are asking clients that are participating in this program, what I have them do is I have them write 2 checks. They write one for $25 and they write one for $75. I put those checks in an envelope, they get locked up for the year. I don't even cash them. If they meet the attendance requirement, that is their trigger to get their deposit back. So we have 9 out of the 16 classes that they need to meet during the core sessions. Once they reach that, we give them $25 back. They need to go to at least 3 out of the 6 sessions for the post-core, and then they get the other $75 back. I do not give those back when they reach that. I try to give those back at the end, because the last thing I want to do is say, here's your money, and say, oh, thank you, and there's still 3 other classes. And we let them know too, it's really important that you attend all these classes. That's where you're going to get that success. But we implemented the deposits so that it kind of separates those that are really committed and ready to go. And I haven't gotten any feedback yet that it's been a barrier, especially with us not cashing those checks unless they quit showing up. So this is actually, it's not looking quite right, but this is what the model should look like. So what it is the participant can go ahead and refer themselves into our program. They can self-refer, or their provider can refer into DPP. We have a very easy enrollment process on our website. It basically asks their name, phone number, address, how I can get a hold of them, and then as the DPP coordinator that I fulfill that role, I then contact them and get all the extra information of what class works best for you, here's when it's going to start, and all that good stuff. So Mercy Medical Center North Iowa is providing us funding to help support the facilitation of DPP, which is wonderful, and it helps. As I mentioned, we have minimal county tax dollars, but the Mason City YMCA did not have the resources to put towards this. So this partnership has worked out great. And then we also are looking at those providers within that network to go ahead and start referring patients into it. We're wanting to start these classes every 3 months so that we're not losing that motivation from those individuals that are wanting to start. All of the data that comes from those classes gets sent to me, and then I put them in a tracking mechanism so that I can submit our data to CDC. So our expansion of services that I had mentioned, we want to have these classes starting every 3 months. That's been slower than anticipated due to some staffing needs. Both my facilitators had babies within 4 months, so I needed to slow things down a little bit. But they're back and excited, and so we're hoping that we can get that started. On top of, we're looking for another lifestyle coach because there is a high burnout. You do need to be careful and not overload your lifestyle coaches. For the long waiting period, what we're doing when they're on the list is there's other programs that we can get them in to keep them going. We have a 12-week WellFit program with the Mason City YMCA. They can come and work with a personal trainer for free for so many sessions. At Public Health, we have a registered dietitian and a personal trainer that can help them at least keep the momentum going until they can actually get into the program. Again, we started the new refundable deposit, and the results are very promising. We're at 92.8% retention rate, and this is on the group that they finish up in a month. So we went from 54% to 92. It's helped a lot. Now, I don't know how that's going to work for the programs that are already, they're paying for that already. I mean, if they're already putting $500 in to attend the class and they're not showing, then this probably isn't going to work. But there may be other reasons why they're not coming. But this has at least helped solve our problem so far, it's looking like. We have had a 2-year commitment for community benefit funding to help support our program as well. And I'm really trying hard to try and keep 1 class per coach to help with the burnout. I don't know that I'll be able to do that all the time, but that's really what we're trying to do anyways. There's still work to do. We want to add, like I said, additional lifestyle coaches to our team. We are looking at expanding to the Hispanic population and doing Spanish-speaking classes as well. That is definitely a need that we need to be looking at. Again, we want to start offering more classes quarterly versus biannually. And we all, as a group here, we need to continue to advocate for insurance coverage. I always say if this class could be put in a nice little pill, it would be covered, but for some reason, it's not. So I think as a group, we need to all continue to advocate for that. These are my lifestyle coaches. Kelly Gertis and Caitlin Nicholson work at the the Cerro County Department of Public Health. One of them is a personal trainer and the other one is a registered dietitian. We do offer one free one-on-one session with the dietitian if they want to. I try to encourage the facilitators to tell them to wait a little bit so that they get a feel for where they're at in their program and where their needs are, and then they can really hone in on what is it that they want to work on. We also have 2 from the Mason City YMCA, Casey Curro and Andrea Johnson. Casey is a wellness and sports director, and then Andrea is a cycling instructor. And I will point out that Andrea, she does classes, and she was a little hesitant to do this, and she's done phenomenal. She's had the best outcomes ever. So I'll throw that out there too, that you don't need a nurse. You don't have to have a registered dietitian to do this. It's somebody that can connect with the people and help guide them and facilitate them in conversations. So don't lock yourself into just looking for those licensed individuals when you're looking for lifestyle coaches. Okay, I think I'm going to wait on the questions. If you have any, go ahead and jot them down just so that Carol can go ahead and present hers. And if that's okay, then we can just do questions at the end if there is any.
So while Karen is calling up the other PowerPoint, how many, if by show of hands, how many here do DPP at their site? Okay. And how many are interested in starting DPP and that's why you're in this program? Okay, that helps. Oh, thank you, Karen. So one of the things I want to do too is you've heard from two great programs, you've heard challenges, you've heard sustainability, you've heard successes, and that has been very similar to the experience in Marshalltown, so I'm not going to go through as much of that with our program, although we do have our program coordinator here in the room, so if we need some questions about that and guidance on that, I'm going to defer to Keisha. But what I want to talk a little bit about is some of the things that really affect the success of your program if you're looking at starting up a program. So it's really important with DPP that you are seen as a partner, a respected partner in the community, and that you're looking for other respected partners. And so whether that's county-wide or community-wide, the partnership really does help because it helps you mobilize the resources necessary for this program, because this really is a marathon. You know, this is not something that just picks up, takes off, and you're good to go for the long term. It really is a marathon. You have some ups and you have some downs in a program. And as you can see, I won't read the whole paragraph to you, but you can see the CDC information from this. It identifies mobilizing resources, influencing systems, and changing relationships. So my S dropped in on this format, but what that translates into for our experience really is partners, breaking down barriers for people, not only for participants but also for partners, and then outcomes. You know, can we produce the outcomes that we're talking about? So just a little bit, I've sprinkled in a little bit about our history in Marshalltown. You know, DPP, whether it's through the YMCA or whether it's through NDPP with CDC or what's upcoming now in Medicare, it's a proven program and there's a lot of evidence behind it. So, you know, you can really make a case with partners as to, you know, why this is a good investment in your community and in the health of your participants. We started our first pilot class in 2011 and did an outreach with our local healthcare community. In 2012, we worked through a community transformation grant, and actually one of our first major partners was our community college with the Iowa Valley Community College Education and Training Center, and that is a center that really works a lot with new immigrants and people that are speaking English as a second language. And so we were painfully early in the development of Spanish materials for the program. We actually were doing the program and working with the National YMCA to develop some of the materials in Spanish because they were still in the works. But that partnership was really critical in the success of that program, because this training center really was seen as a trusted resource for our immigrant community. And so for us to go and try and reach out to the immigrant community ourselves and say, you know, we have something great that we think would help you, it really made more sense to work through a trusted partner at their site where some of our families and participants were used to going. Another thing I want to, for those of you who are doing DPP, how many have an advisory committee as part of it? Okay, a few, yeah. So that's been an important piece for us because, and we'll get into a little bit more detail on who's on that advisory committee, but this really is a dual approach, you know, bottom down or top down or bottom up, grassroots up. As you're building and starting a program, you know, certainly you want to work with the obvious partners, your healthcare partners, but then you look at who in the community has connections to your target market. And so sometimes that's working with the established healthcare system, sometimes it's not. And so you really have to look from leadership levels in our partners to the program and frontline people in our partners as well. And we try and work both sides of that equation. And then we take a look at, so how can we get our community involved and engaged in this? So stakeholders, we through the YMCA model, have an advisory committee. Those are champions for our programs. They're not all healthcare providers. Some of them are actually people who have diabetes already and have a current interest in helping our community and those with pre-diabetes. Some of them are prospective funders. We talk particularly about referrals for the program, and then taking the program to wherever it makes the most sense to do it. Sometimes that's at the Y, sometimes it's at the hospital, sometimes it's at the education and training center, sometimes it's in a church. It just depends on who you're trying to reach and how is best to engage them. And then, of course, as Karen talked about and some of our other partners have talked about, community presentations. So, service groups in your community are often looking for programs, and oftentimes those programs and meetings get in the newspaper and get covered in smaller communities. So that's a good way to get the word out about your program as well. So it's really about when you're brainstorming on who your partners could be in this, find out what works for them. There are lots of different ways to be involved and support. So this gives a little further explanation of some of the sectors. Obviously in the healthcare sector, you have systems, clinics, and hospitals, but you also may have community health coalitions. So in our community since 2005, we've had a Healthier Communities Coalition. And the work of that group has evolved over time, depending on projects, depending on funding availability, depending on what initiatives they're working on. Sometimes it's systems, sometimes it's environmental work, sometimes it's, chronic disease prevention. So we really try and focus in on where the interest is with our partners and looking at who else could be at the table. So senior centers, as I mentioned, churches, other community-based organizations. Other than the Y folks in the room, which some of those I know, any other community-based organizations here outside of hospitals and physician clinics and public health? Any other? No. So, that's why we really do have to kind of work to reach out and find partners that can help us expand this program to help it be successful. So an example of the kinds of partners that we have on our advisory committee, this is a group that for us meets quarterly. We talked initially about with our partners, how do we want to engage them? How often is productive to meet? How often is too much? And we settled on quarterly meetings. So we have as chair of that group a retired physician. He's a gentleman that has a real interest in population health and has been pretty active in the community, and he's been a real champion for the program. We have our hospital leadership, so for a while, over a period of time, it's been the CEO, but usually if that changes, someone on the executive level staff, because it's really helpful for this group to have some of the decision makers for the stakeholders at the table as well, in addition to some of the frontline staff who are delivering the program, because when you need resources, when you need doors open for you, you really need the leadership of the organizations to help with that. Our physician clinic leadership, public health representatives, we also have corporate wellness represented as well. And so I think as you heard, employers, the hospital has been at the table as an employer in addition to as a healthcare provider. So we actually did classes at the hospital for the hospital employees as well, but then they were also at the table as a community healthcare provider. So physicians clinic, healthcare systems, any of those are also major employers in your community as well. And so we approached it that way. And then of course our dietitians and diabetes educators, For us, it was important to have a volunteer who's on our board be a part of our advisory group, because it was important for us as an organization to show our support to our community stakeholders. And when you have volunteers giving of their time, they're leaders in the community and they're leaders in our organization, it does show that the organization is behind it. And of course, I have been involved. Don't overlook just community volunteers who really have a passion for this. You know, they may or may not be working in a system, they may or may not be working in a hospital or a clinic, but they're a volunteer maybe with some expertise in their background, or just have a real passion for this and have some really nice connections in the community to help get the word out and help get you in front of others who would be interested. And then of course our coordinator and our health and wellness director, who, you know, bear the lion's share of the reporting that we do at each of the quarterly meetings. Okay, so looking at barriers, I think the other programs, and particularly Karen did a nice job of highlighting some of what the barriers are. Probably the major barrier for community-based organizations, it's a little bit different if this is a hospital or a physician's clinic, but one of the major barriers for community-based organizations are referrals. And so for us, it was important that the healthcare systems, the physician's clinic and the hospitals saw us as a credible, trusted partner, which meant we had to be able to follow the same standards, particularly HIPAA, when referring patients. And so, you know, there are different models from around the country with community-based organizations and how to refer. There have been, you know, ideas like prescription pads and paper form referrals, electronic referrals, and you know, if you're really more advanced in some of the software and connected with that with EMRs, you can do website portals. So when you have these kinds of systems set up, it can be paper, it can be as highly developed as EMRs, but it just needs to make sure it goes both ways. That you know, the physicians and the providers know about your program, they know the results, and you're communicating regularly with them about how you're treating and reporting on their patients. So one of the things we talked about early on was, could we get prompts in the EMR system with our providers? That's easier said than done sometimes, you know, when they have their established prompts and things, you know, to add one more thing to a physician's office visit isn't always an easy thing. You know, again, as a community partner, you have to be flexible with where your partners are at. And if they understand the value of your program and start seeing the results and you're communicating with them on outcomes, I think, you know, you get a little farther down the road. But certainly, if you can get prompts in an EMR during an office visit on these things, that really, really helps the process. And as we know, especially with, well, with all patients, but particularly with Medicare age patients, if it comes from a physician, if it's a referral that comes through their physician or a trusted healthcare provider, it really does carry more weight with them. And then of course you want that to be institutionalized. So you want that referral system set up so in a way that if people change or people move on for different reasons, there's a good system in place that it doesn't go away if someone leaves their position. And it is important as a community-based organization or as any provider of DPP that you are seen as this trusted source of care, that you're responsive when physicians refer or healthcare providers refer, and that, you know, you're communicating with them. Other partners, we heard from office managers. Actually, sometimes they can be your biggest advocate for these kinds of programs. And of course, a lot of hospitals and clinics have community outreach staff. And so this also can be helpful for us. And then your pharmacists in your community can be very helpful for this. So, as Karen and talked about earlier, and we've experienced as well, sustainability for this is a challenge when you don't have third-party payers. As more insurance providers come online, as Medicare gets up and going a little more, as employers recognize the value of this kind of investment for their employees, I think this gets a little easier for us, but it is still a challenge when you're asking people to pay out of their pocket for a service that they may not feel the pain of their disease yet. We're a YMCA that provides Livestrong as well, and Enhanced Fitness and DPP. So we do kind of a variety of evidence-based medical programming. But this is one that until someone actually experiences some of the pain of the disease, it's a little difficult to get their commitment on this. Whereas with Livestrong, you're helping cancer patients or cancer survivors who they are highly motivated to kind of reclaim some of their health. So it's a different kind of approach with this, and it takes a lot of education and a lot of patience and a lot of empathy that you can help people understand why this is really important for them. And then of course, each of us has different demographics in their community, and it's not a one-size-fits-all. We experienced in our community with some of our Latino population, there almost was an expectation, especially among women, middle to older women, that they would get the sugars no matter what. There wasn't anything they could do about it. It just was a natural thing. And so, it takes time sometimes to re-educate and to help people understand what's happening and why it's happening and why it's important to try and prevent it. And then of course, in your partners and even within your own organization, things change and people move on. So you may have lifestyle coaches trained and you think you're ready to go, and then you have a change. Or change in leadership in one of your partners, and then priorities change. So you just have to constantly be working and communicating about what the benefits are of the program and how that can help your community. And of course, the good news for this is this really is on the radar screen of some funders now, much more so than it used to be when we started in 2011. So there is grant funding out there, and as we said, we're moving towards some third-party payers. And then it's also important to engage a variety of community stakeholders so that this is a problem, this is seen as a community issue, not a hospital, not a clinic, not a Y issue. So in Marshalltown, we are a CDC recognized program. We are a health partner in integrated healthcare. I'll share just a little bit. This has mostly been covered, so I won't spend a lot of time here, except to emphasize for those interested in Medicare reimbursement, it is required that you are a CDC recognized program. So it's worth investigating what the steps are for that. And then as a part of our DP program, I just wanted to just give you some examples of how we track data and some of the information that we track. And then I'll highlight this. Testimonials are really important. Sharing the success, I think as Karen referred to, the patients or the program participants who shared with their physicians the success that they've had in the program, the support they've had in the program, the lifestyle changes they've been able to make in the program. That's important for you as program coordinators or wanting to get started with the program to capture those testimonials, because that can be really powerful for physicians, and it can be powerful for others interested in taking the program. So we, through a shared service agreement with the Des Moines Y, actually offered DPP here in Des Moines. We had some employers here in Des Moines who had this as a covered benefit for their employees, and the Des Moines Y was not certified in it, so we were able to help out with that situation. And you know, it's really, again, pretty powerful when one of the participants can really cite the numbers and talk about the differences it's made in their health. And for an employer especially, you know, if you're making an investment like this in your employees, they want to see concrete results, and they want to hear the anecdotal information from your folks as well. So it's important, the tracking, you know, we're pretty good at as you know, professionals, but it's also important to get the anecdotal stories as well. And just some of our 2017 data. And then I thought I'd show you, again, promoting your program. So this is just one of our flyers, and you know, the face of diabetes is pretty diverse in Iowa. So we try and show people of all ages and people of all backgrounds. So you want to, as you think about how you're going to promote your program, who your target population is, who you want to serve, you need to think about that as well when you're working on your materials. And so I think now Karen or I am available to take some questions if you're wanting to ask anything.
I wondered did Mercy end up putting it on their benefits in Mason City? I was curious as to whether that was something they did.
Mercy, they put it on their benefits?
Is it part of their insurance coverage for their employees? Sorry, I didn't say that very well.
I don't believe so, but that wasn't part of our program. I don't know, to be honest, but I don't believe so.
Okay.
Yeah. One thing that I didn't mention before too, we do a session 0 as well, and one thing that's helped is bringing in a past participant to tell the incoming participants about their journey. Lesson learned though, make sure you have some sort of prepared, here's the things we want you to cover. Yeah, sometimes they like to educate the group of what they've learned, and maybe isn't appropriate, but it's helped.
The first question is, or you talked about deposits. Could you explain how you set up this 25-75?
Yeah, so it happens at session 0. Like the previous speaker, that's when they make the commitment to whether or not they want to join the program, and if they do, we have them write 2 separate checks. We have had some cash and we just put it away, but if they can write 2 checks, once for $25 and once for $75. And if they meet the required attendance guidelines that we put forth, then they get those checks back. So we don't even cash them unless they don't meet those requirements.
And if they don't meet them, you take them, you cash them both?
I
don't understand why you have 2 different checks.
Yeah, so the $25 goes for the core sessions. That's the 9 out of 16 sessions. That's what we put as a requirement. You could put whatever you wanted, but we were trying to coordinate it with at least the CDC's DPRP standards. And we wanted to keep it so that we don't want this to be a financial barrier, so we needed to keep, we're a recognized site as well, and we want to keep that recognized site so that we can eventually be able to bill insurances. So there was part of it that was sustain our program, but the other part was making sure these individuals are coming to the program and not taking a slot if they're not necessarily committed. So, and we've had this question too, where they're like, well, why do I have to go to 9 classes to get $25 back and then only 3 for $75? But that was where we were seeing the dropout, was the post-course, so that's why we put that bigger at the end.
Are you guys having any luck with young people, getting young people enrolled? Because we really aren't getting many young people to enroll. So I'm curious if anybody's had any success with that.
So I'll defer to Keisha and our experience with that.
Yeah, we have had some young people. Actually, one of those folks is a younger person that Carol shared. Yeah, the big thing is just offering a time of day that they're available to come. Right now, we're offering a noontime class, and it's actually all working people, which has never happened in our noontime classes before. But our coach is also a working individual, so he's very respectful of needing to stay in that lunch hour, and it just works for them. But I think offering the right time of day, the right day of the week, you know, younger people tend to be a little bit busier as far as their social life and that kind of thing, so making sure that you stay where they can come.
We've also reached out to the OB department, and as we're trying to capture that gestational diabetes group. Our evening class is purposely held at the YMCA because they have some child care options there if they need to. And we definitely see the difference in the age group just from our morning and evening. The morning one tends to be the older population that is retired, and then the working class, or the working population is doing the evening class for the most part.
When you collect those checks, do you actually hold them for 6 to 9 months?
Yes, we do.
You're reaching havoc with balancing my checkbook.
Well, if you show up to class, you get it back.
But wouldn't it be easier to say you cash the checks and tell the patient, if you go to 6 months or 9 months, we will write your checks back to you, because some people like to balance their checkbooks, but if you're holding them for 3 months and 9 months, my God, by the time 9 months comes along, it could have had a new baby practically.
Well, 2 thoughts. One is, again, we didn't want to make this a financial barrier, so if we didn't have to take that money from them at all, we didn't want to do that. And secondly, I work government and claims and courthouse, and it would be a nightmare. So the easier way was to just keep the checks. And it's worked. I mean, everyone's...
Yeah, well, you better warn them ahead of time that you may not check the cash for 9 months.
Oh, we do. We do.
Yeah, did you have a question?
I did. Do you offer makeup sessions, and then how do you handle those when you do that?
So I'll let Karen go first, and then okay. So yes, and I'm going to defer to Keisha again on that because she's the one who actually handles those.
Yeah, we do offer makeup sessions. We don't require ours. So it's more of a, if that participant wants to make up that session, our coach is available to make it up. They set up a time together, one works for them. If they're not interested in making up that session, you know, it's just a crazy week, crazy month, then we still supply them with the materials from that session so that they can read about it and still get that little bit of education piece, but they wouldn't get that one-on-one conversation with the coach.
So if you have someone that's missing some session, does that become a problem then if you don't offer those makeup sessions for your attendance and what you're turning in with your data for the CDC?
I would think you would want to offer them and at least get the materials to people at the very least, because it does become a problem. They, you know, you have to attend so many. Yes. Yep. Yeah. I think you want to do as much as possible to get people to class, and Karen emphasized that and all the changes they made to try and keep people in class.
Yeah, it's nice to get the information, but they're missing out on that group discussion. That's really what forwards that program. But we're very similar. We'll offer it, but we don't require it. and we don't set certain times, they need to make arrangements with the facilitator.
I think we have one in the back and then we'll come up.
Yeah, it was just kind of going back on the check thing. Have you run into any problems with banks honouring checks that are older than 6 months?
No, we haven't yet, but honestly, we haven't, to be determined, because we really have retention, so it's been working, but no, we haven't. And we always have that possibility that they may close their checking account, they may not have the funds. It was a risk we were willing to take. We were just trying to find one other way that we could make sure that the individuals are committed, and if we lose out on the money, that's not, we weren't doing it for the money, we were just really doing it to make sure that the patients or the clients are staying committed.
And so are your classes running simultaneously? So like if I couldn't make it to a noon class, I could maybe come to Thursday class in the evening? You know, are they interchangeable?
Yes, we do. We try to tell them to stay to their class, but we know life happens, and if they've got a conflict in the morning, they can make the evening one, they will do that. And the data is being shared back to me anyways, no matter which lifestyle coach it is, so I'll still get the information. I just think that they're going to fare better if they're with the group that they're used to in the discussions, but yeah, we do allow that.